I think we must adopt prevention techniques. We have an aging population, we have osteoporosis, we have the tragedy of road traffic accidents, we have lifestyle-related disorders including sarcopenia, we have sports and occupational injuries, we have congenital diseases and early detection, we have advances in technology, we have wearing technology. There's so much things to be done we can do for prevention. So starting with osteoporosis, osteoporosis is known as the silent thief. The osteoporosis thing has become so advanced that the 2010 decade was known as the bone and joint decade because the osteoporosis thing was too overwhelming. The disease characterized by weakening and brittle bones casts a long shadow over India's public health landscape. Millions of Indians grapple with the silent thief, often undiagnosed until a debilitating fracture occurs, exposes the underlying problem. Studies suggest that nearly half of the adult population suffers from osteopenia, and a staggering 1 in 5 have osteoporosis itself. This alarming statistic is further compounded by the fact that osteoporosis disproportionately affects women, particularly those who are menopausal. So, you know, what happened was, it was in 89, I think I started my practice in December 89, and the first 5 years went just in trying to set practice up, get a foothold on living life, settling myself in my practice, settling my family, educating my children, all that. Slowly, as I started getting closer to my patients, I realized the economic, social, financial repercussions of what they were undergoing. Then gradually I realized that I am fortunate to be in a branch of medicine where we can do immense work to prevent these problems. They did not have undergone through it at all. It was then I started getting more and more passionate about prevention in orthopedics. So the first, this thing is orthopedics, osteoporosis. The osteoporosis, the problem is gradually, as you can see, the demographics show that the curve is getting more fatter in the upper age group, and we have more and more aged people. So you need screening for osteoporosis, individuals with previous fragility fractures, especially in weight-bearing areas such as hip, spine or wrist. Then you look into risk factors like smoking, hysterectomy or oophorectomy, postmenopausal, ovarian function, and you can even do quantitative ultrasound. What I want to drive home the point is that finding a case, whether it's osteoporotic or not, is not difficult. You can have the osteoporosis self-assessment tool for Asians, OSTA, which is a simple formula of 0.2 into body weight minus age, and -1 is low risk, -1 to 4, -4 is moderate risk, and less than -4 is high risk. So, you know, it's so easy to find out on a cursory note whether he needs further investigations for osteoporosis. All we need to do is to open our eyes and be alert. Then we have the FRAX. The FRAX is another paper tool which you or your staff can fill it for you, and you can find out if their chances of getting a refracture is high or not, and you can prevent fractures. The FRAX tool can be done with DEXA, but it can also be done without DEXA. If it's a male, it's preferable to have a DEXA, but without DEXA is also quite acceptable. You need to screen high-risk people like rheumatoid arthritis and those on steroids for long periods of time. The preventive strategies includes, of course, physical exercise and diet recommendations. You have sports activities, regular planned physical activities like weight-bearing and resistant exercises. I'm not going into details of each one. You are all fully aware of all this. Fall prevention strategies, will come through this later. And it is very interesting that you don't have to refer the patient to a physiotherapist for prevention of osteoporosis. That is not necessary at all. And then you have other strategies like attending group exercises. You know, there are a lot of psychological advantages of group therapy. So do encourage group therapy. A high level of coffee, the 800 milligram would be more than 2 cups of coffee, should be discouraged, and a high level of sugar consumption also leads to reduced calcium absorption. And we need to take care that the patient doesn't develop secondary osteoporosis because of some other thing. The next thing we come to is sarcopenia. Sarcopenia is something which is really bothering us, and it's coming more and more to the forefront. Advancing adult age is associated with profound changes in body composition, the principal component of which is a decrease in skeletal muscle mass. See, the whole ball game is the decrease in skeletal muscle mass. Age-related reduction in muscle is a direct cause of the age-related decrease in muscle strength. Muscle mass, not function, appears to be the major determinant of the age and sex-related differences in strength. Reduced muscle strength in the elderly is a major cause for the increased disability, prevalence of disability. With advancing age and extremely low activity levels seen in the very old, muscle strength is a critical component of walking ability. Now, how do you know that the patient has, how do you screen a patient for sarcopenia? One thing is, they have a simple questionnaire called the SARC-F. The SARC-F is strength, walking or ambulation, rising from the chair, climbing stairs, and fractures. It's a simple questionnaire. You just mark it, get the points, and you know if the patient is getting to be sarcopenic. So just an awareness of that, you need to be aware, especially after 50. It will be a good idea to target those who are a little high risk for this and then make them fill this questionnaire. The SARC is one part of it. The other part is, you see, sarcopenia has manifold effects, so you need to tackle it. The sarcopenia assessment, apart from SARC questionnaire, you can do a simple muscle grip strength. Now, you can have this simple dynamometer. It's called a dynamometer. You can have it on your table. It doesn't cost more than 2,000 rupees on Amazon. And I see a lot of my patients playing around with it if it's there on my table. And all that you need to do is ask the patient to grip it, pull it, and if it's more than 25 for male and more than 20 for female, then generally you're safe. So it's such a simple practical test for sarcopenia. So why don't we just have this extra thing, and it solves the patients with a lot of problems. The other thing we need to be aware of is that we need branch chain amino acids to prevent sarcopenia. Which are the branch chain amino acids? They are leucine, isoleucine, and valine, and they are not manufactured in your body. You need to take it from an external source, and so the protein which has all these amino acids are called whole proteins. Unfortunately, as vegetarians, if we are a vegetarian, see, for example, milk and egg is a whole protein, but if you are a vegetarian, pure vegetarian, there is no single protein which can be called a whole protein. So you have to mix the proteins, something like a khichdi, and that would be very good for you. So you need to take your proteins, not just proteins, but you need to take it intelligently. Our requirement of protein is 0.8 gram per kilogram, and we are woefully short of it. So we need to improve our diet as far as to improve sarcopenia. The essential amino acids has got a lot of advantages. So now we come to focusing on diet and bone health. Of late, the understanding of diet and the role it plays in everything is getting better and better, and the comprehensive list of foods grouped by nutrient types that support bone health is getting more and more crisp. We have calcium-rich foods, we have vitamin D sources, we have protein-rich foods. As I said, we must have whole proteins, magnesium-rich foods, we have vitamin K-rich foods. There are so many avenues, phosphorus-rich foods, which can help us improve our bone strength and muscle strength. Vitamin C-rich foods, omega-3 fatty acids, zinc-rich foods, boron-rich foods. These trace elements do amazing work, and all this is not difficult to care of. Maybe you need to seek the help of a qualified dietitian before you go into this. The third thing which has improved our understanding of all these diseases, the degenerative diseases, is the microbiome. The microbiome, the gut microbiome, is touted as the second brain. It is so important for a whole load of things, and the alterations in gut microbiome can significantly influence the metabolism of calcium and vitamin D. What you can do is to get a biopsy, or you can get analysis of the gut microbiome, which is eminently available in all the major cities, including Ahmedabad and Baroda, and try to reorganize the diet so that the calcium absorption gets better. The other thing which is perplexing us and which has stumped us is our uncanny claim, a very bad claim, to being one of the world's highest road accident prone areas. Approximately 1.19 million people die, all of them in the third world countries. 92% of the global road fatalities occur in low and middle income countries, despite having only 60% of the world's vehicles. More than half of the road traffic deaths are among vulnerable road users, and road traffic costs a lot. We have, as the Indian Orthopaedic Association, we have been trying to do something. We have even gone to the Supreme Court, tried to bring in laws. There are changes which are occurring. I think it's more of a social change, so it's taking time. But India still remains on the top of the list with the maximum number of road accidents. India still counts road accidents, road injuries, as one of its main causes of death, along with heart disease, tuberculosis, and diabetes. That's very sad because it's very preventable. How do you deal with it? You can prioritize road safety interventions. We establish a national database for fatal crashes, public access and transparency, monitoring and evaluation, leveraging technology. The AI-driven traffic monitoring can help us. Driving under the influence of alcohol has to be more strict, and non-use of motorcycle helmets, seat belts, and child restraints is so alarmingly and surprisingly prevalent that a correct helmet use can reduce the risk of death in a crash by more than 6 times, and the risk of brain surgery by up to 74%. Imagine if you can talk to your patient that why don't you think about your child when he goes out, you have to see that he is well protected. Distracted driving, I remember last 10 years, the American Academy of Orthopaedic Surgeons, their annual conference, has got one cash line, decide to drive. They have an interesting experiment. They make a small park in the floor of the exhibition ground, and then there are 2 or 3 cars with a lot of traffic kept in between, and then you are given a remote, and then they'll ask you to drive the car while talking on the mobile, and you'll be surprised to see how many times you fall into an accident. So that you need to educate people about distracted driving. Unsafe road infrastructures, unsafe vehicles. Actually now the government is thinking of speed governors so that the vehicle can't go above a certain speed. Right now we already have above 80 a beep and above 120 a continuous beep if the speed exceeds that. Because what happens is as you increase the speed, it's a very interesting statistics. The risk of, for every 1% increase in mean speed, there's a 4% increase in fatal crash risk and a 3% increase in serious crash risk. In a car to side impacts, the fatality risk for car occupants is very high. Then we come to the other aspect of prevention of sports injuries. See, there are so many areas where we can help in prevention. I'm just picking up a few where I thought we could really help. And prevention of sports is getting to be big business. A lot of people now getting into serious sports, but you also have the occasional Saturday, Sunday cricket player who would like to have his packet of fun. So you can prevent a lot of sports injuries by warm up and cool down, by staying hydrated, by using proper equipment, by taking breaks. I was talking to an international cycling coach, and he said these Indians are very good. They are very hardworking in their sports. The only problem is they don't know how much to rest. So we don't rest adequately. We don't allow the tissues to recover from the insults that they undergo in our zeal to perform better. We must listen to our body. The classic warm-ups, any standard physiotherapy setup will show you the standard classic warm-up. The sports and physiotherapy training, you need to now slowly go to professionals who will train you how to build your stamina, how to build your muscles for the specific sports that you play. But generally, it's strength training, it's compound exercises, it's light resistance exercises, circuit weight training, flexibility exercises, dynamic stretching, foam rolling, stretching, balance and coordination exercises, single leg stands, planks, plyometrics, cardiovascular conditioning. Now, all these are generally, but I am taking cricket as one example so that it drives home my point, because cricket is the most popular and more prevalent game played all over India. Generally, you need to do a lot of running. So you need good hamstrings, quadriceps and calf muscles. In batting, the upper limb structures such as the shoulder and chest plays a significant role. The hips, buttocks, lower back and core muscles are also very important. In bowling, it places a great deal of stress on the core muscles and the rotator cuff muscles of the shoulder. In fielding, you need good muscles for throwing. These include pectoral muscles, rotator cuff muscles and the forearm muscles. And so they will also give you 9 essential strength and power exercises for cricketers. Now we need not learn them, but we need to send them to a specialist who knows that these are available. So you need to develop a fitness plan, get enough of sleep, cross-train and set realistic goals. Now, these are just not for those who are professionals. Even those overnight cricketers who want to play their Sunday game, you ask them to go warm up, do their stretches, lest they injure themselves. The suggestions for senior citizens, I think this is very important. They are very small suggestions. They are very simple rules. We need to just reiterate them in our mind so that we don't forget when we talk to our patients that these are the things we need to educate them for. Never stand on a chair or stool to get something. Don't go out on rainy days. Use an anti-slip mat and don't wear your underclothes in the bathroom taking support of the wall. You must sit on the thing and then wear your this. Be sure to clean up the floor of the bathroom, keep it dry, clean up the floor so that nothing comes in the way when you get up. Getting up in the middle of the night, you must have the light near you and do not close the toilet door. These are very simple suggestions. There's nothing very great about this. But I'm just reiterating that there's so many suggestions we can give to make the seniors safer. In the trochanteric pads, for example, are not scientifically still proven, but maybe if those who are 90 plus, they can be protected with trochanteric pads. So fall prevention is a strategy you must think of when you address a senior. The other thing I just wanted to touch on that, these things we don't think about much, but there's a lot of help you can give by genetic counseling because you're in touch with patients and maybe you can counsel the patient, the parents before they fall into another trap. So you need a lot of, you can do a lot of patient education and you have to you can get tests done. It is very surprising that half of us don't know that these tests are available in Ahmedabad and Baroda. It helps in early detection of conditions like scoliosis, spinocerebellar ataxia, or lymph girdle muscle dystrophy, or the preventive measures can be helped by knowing the malady they can get into. So the genetic testing can help healthcare providers create more effective treatment plans also. See, these tests are not impossibly costly. They are costly, but they are well within the reach. The amount they save in terms of healthcare costs is absolutely, you cannot match them. So, gentlemen, finally, we have early risk assessment programs. You can have bone health clinics, screening for skeletal conditions, AI-powered predictive tools, gait analysis, and injury history. We can have lifestyle intervention programs. We can have physical activity programs. This marathon running is one of the good things because people really work hard for it, train themselves, and then do this. Physical activity programs, workplace ergonomics. We have people sitting on the computer for a long period of time, or repetitive strain injuries of the carpal tunnel. All this could be addressed. Sports injury prevention is what we saw all about. And then we have awareness drives for osteoporosis. Last year, we educated more than 10,000 school students on osteoporosis. See, what happens is the peak bone mass is between 15 to 17 years. And if you have a proper peak bone mass at 15 to 17 years of age, you are partly insuring them against osteoporosis when they reach 50. So there's a lot of things. We are even trying to go to the Supreme Court and get a law for schools to keep them outdoors at least 15 minutes between 12 and 3, which is what is the WHO recommendation. We also talked to geriatric groups, and we also talked to university students. So we did a lot of work on awareness programs for osteoporosis. We can have community workshops teaching the rules of this thing. Then we have, of course, technology integration. These smartwatches are amazing. Their conditioning strategies are amazing. And you can use smart devices that track movement, posture, and activity levels. Telehealth, you can have long-term, long-distance consultations with telemedicine platforms. You can have 3D gait analysis. All this, incorporating prevention into clinical practice is of prime importance. All of us are doing that, but we need to spend a little more and catch these high-risk patients before they fall into trouble. The way forward is a collective effort required by healthcare professionals, policymakers, and individuals. Public awareness campaigns, school-based physical education reforms, and workplace wellness programs, and preventive mindset by orthopedic surgeons, educating patients about lifestyle modifications and emerging technologies. The question isn't whether preventive orthopedics is necessary. It is how quickly we can embrace it before the burden becomes unsustainable. The conclusion, health is not valued till sickness comes. By prioritizing prevention, we can choose the way we approach musculoskeletal health. The paradigm shift not only enhances individual well-being, but also strengthens communities and healthcare systems. As we move forward, embracing prevention as the cornerstone of orthopedics is not just a choice, but a necessity. These are some of the references. If anybody would like to have something, they can always contact me. Thank you for such a patient hearing, and I am humbly, my head bows in humility as I thank you for your attention. Thank you.
Thank you so much, Dr. Rao, sir. Prevention is better than cure is an adage which we have heard right from our primary school days. And Dr. Rao definitely showed us in his talk that it is definitely a Pandora's box. We have so many avenues, we have so many choices, and it ultimately matters down to what Dumbledore said. It is not just a matter of our abilities, it is a matter of our choices as well that dictate ourselves. And to attain success in our practice, we must understand that if the treatment and cure of complicated and complex cases is definitely paying and rewarding, but at the same time, the prevention of all these conditions is certainly much more satisfying and fulfilling. Thank you very much, Dr. Rao, sir, for opening a Pandora's box on all this. And we would like to felicitate you on this occasion of delivering this past president talk. May I ask the president, Dr. Vijay Sata, to do the honors, please.
Moving forward, inviting Dr. Mandip Shah to be on the dais. Ever charming, ever handsome, and ever smiling, onco-orthosurgeon from Gujarat. And he is going to present to us the Young Surgeon Forum, one of the very initiative step of Gujarat. And he is going to talk about utilization of standard reverse shoulder arthroplasty with sterilized bone in cases of sarcoma, selected sarcomas, and avoiding megaprosthesis. All yours, Dr. Mandip, please.
Thank you, sir. Thank you so much, chairpersons, the president, sir, the secretary, sir. I first, at the outset, would like to thank the Gujarat Orthopaedic Association and the jury that they found this paper worthy of, this prestigious award. Well, it is more humbling because I am standing and receiving this award for a second time. In 2019, Dr. Naveen Thakkar, sir, had given me this award for my work on giant cell tumors. But today I'm going to talk about something entirely different, for which I can probably take a credit of envisioning this procedure and performing it on more than 20 patients and coming up with this data. This research has taken place at my clinic, and I would like to thank my co-authors, Dr. Chetananchan, Dr. Vishnu Ramanujan, and Dr. Kinjal Jani. We all know that proximal humerus is very frequently affected with malignant tumors. It is actually a third commonest site after femur and pelvis. Majority of the patients of proximal humeral sarcomas would present to us like this with large masses. And when we do a limb preservation surgery for these kind of patients, they lose axillary nerve, they lose deltoid muscles. And that is when you reconstruct this kind of defect without any muscle, without any nerve, the reconstruction that you do is merely a spacer. These patients are clearly communicated that you will not have any function at the shoulder joint, and the surgery is done to preserve the function at the distal joints. However, in around 15% of the cases, the disease extent would allow you for a safe preservation of deltoid muscles and axillary nerve. In this kind of patients, if you put in a simple prosthesis like this, the patient would not have any function at the shoulder joint despite having a innervated functional deltoid muscle, because these patients are rotator cuff deficient patients. We know that when there is a rotator cuff deficiencies, there is loss of compressive load, there is disruption of central line. This leads to imbalance in the muscle forces, leading to instability at the shoulder joint. And here, unless you provide a fulcrum with a reverse shoulder type of a prosthesis, these patients will not have a good shoulder function. Well, reverse shoulder arthroplasty is being done in tumor defects. It's not a new concept. People have done all sort of things. We have reverse shoulder mega prosthesis, and many researchers have done allo prosthesis composite as well. If you look at reverse shoulder mega prosthesis, it is not without any issues. If you look at this paper with 23 patients, just at 2 years, there was 30% revision rates. If you look at this paper, 14 patients, out of them 5 had dislocations, which had to be surgically reduced, but out of those 5, 4 again dislocated. Look at this paper with 10 patients with 4 reoperations for mechanical failure, only 78 degrees of abduction, and only 77% of a musculoskeletal tumor society scores. If you look at this review article of proximal humeral reconstruction techniques, 4 out of these papers are reverse shoulder prosthesis papers, 9% infection rate, 23% mechanical failure rate, 17% reoperation rate, and only 74% of MSTS scores. Even if you do a reverse shoulder prosthesis, because it's a hinged type of a prosthesis, it's a constrained design, these patients do not have more than 90 to 100 degrees of abduction at the shoulder joint. Because these are constrained design, it is likely to wear out faster. The biggest problem for us is its availability. Currently, only one internationally validated system is parked in India. Other local systems are absolutely, flawed and poor designs. And the biggest problem is the cost. These implants from Stenmore or from Mutars are costing around 7 lakh rupees. If you talk about allografts, it is also having a lot of problems. This is a review article looking at allograft prosthesis composite. 36% mechanical failure, 31% resurgery rates. This paper had 7 patients, all 7 had non-union of allograft with the bone. 11 patients, 64% on the humeral side had resorption. 14 patients, 91% had resorption on the allograft side. Again, in India, we do not have a structured tissue donation program, and that is why availability of a good allograft is also a big problem. So that's a sad reality. Mega prosthesis is unaffordable, allograft is unavailable. But there are patients, and we know necessity is the mother of invention. We know that we have these kind of cuff tear arthroplasty implants available to us off the shelf. Really, we have at least 7 companies in India. But this and the results are excellent, validated. But these prostheses are designed to go within the bone. When there is a defect in the proximal humerus, you cannot use this bone. So if by any means we can get the bone back, we could use these implants within that bone. So what we did? We did an oncologically safe resection. We neutralized the tumor within that resected bone with variety of methods. We reimplanted that sterilized bone on the top of the remnant of the humerus, and then again, in that humerus, we use the reverse shoulder, conventional reverse shoulder arthroplasty within the reimplanted bone. So how to do a tumor sterilization? Well, we could use an extracorporeal irradiation, or we could use a cryotherapy. If you talk about ECRT, you know that radiation is cytotoxic and effect is dose dependent. So in a living individual, you cannot give more than 4 grays in a day, but this is an extracorporeal specimen. So that specimen is given 50 grays of radiation, which is almost like a nuclear bomb type of a radiation, which will kill everything under the sun. And we know from large studies and meta-analysis that extracorporeal radiation therapy is absolutely safe oncologically. If you talk about cryotherapy, again, freezing kills the tumor cells, but it preserves the osteoprogenitor cells, maintaining osteoinductive potential. Again, its oncological safety is also validated by multiple research. If you ask me the question, what is better, ECRT or cryotherapy? In fact, a lot of people have done head-to-head comparison and come up with a conclusion that both the things are absolutely similar on all the parameters. So what we did tumor sterilization, did reverse shoulder arthroplasty within the sterilized bone, and did a composite fixation. We call it RAPC, or recycled autograft prosthesis composite. We asked pertaining questions. First question, does this type of reconstruction work or not? Second, what is the complication rate? What is the functional outcome? What are advantages over megaprosthesis, and whether it is more cost effective or not? The indications were very clear. The patient has to be a non-metastatic patient being treated with curative intent. The patient must be amenable for deltoid and axillary nerve sparing resection. We look at the images very carefully. There has to be a continuous rim of fat separating the tumor from deltoid in all the images. Again, we should learn to read the MRI and see if the axillary nerve has to be separate from the tumor and the bone. The tumor board has to certify that this patient will not require post-operative radiation therapy, because you have radiated the bone. If you add another shot of radiation therapy, you are in for a disaster. It's going to non-union. And on clinical examination, patient has to have complete or near normal shoulder range, substantiating that it is a well innervated deltoid muscle and there are no adhesions between the deltoid and the tumor. The bone quality should be good for reimplantation. So these kind of cases we cannot do for a reverse shoulder, this kind of a procedure. We have done 18 patients over last 7 years, 11 males, 7 female, average age 20 years, 8 Ewing sarcoma, 5 osteosarcoma, 4 chondrosarcoma, 1 MFH of bone, 8 patients ECRT, 10 patients cryotherapy. If you talk about surgical steps of ECRT, this is a classical indicated patients, Ewing sarcoma, post-chemotherapy. You do a standard upper humeral resection, preserving the axillary nerve and all its branches, preserve deltoid. The specimen is sent for radiation therapy. Till then, we do the glenoid preparation. We have always used unique from evolutis in all these cases. By the time specimen comes back, we have done the glenoid preparation. Specimen comes back, we prepare this specimen on the table, put the implant within that bone. We make sure that the bone, the implant is cemented within the radiated or cryotherapy bone. The rest can remain uncemented. Then we put it back on the remnant of the humerus, and then we do osteosynthesis. On that, we use a Graver glenoid socket, reduce the joint, and put a Prolene mesh in full adduction for an additional safety against dislocation. This is how the immediate post-operative X-ray will typically look. If you talk about cryotherapy, standard resection with sparing the axillary nerve and deltoid muscle. Away from the field on a separate trolley, you do the debridement of the soft tissues, you ream the canal away from the field, then you dip it into liquid nitrogen, keep it there for 20 minutes for freezing. After 20 minutes, you take it out, keep it at room temperature for 20 minutes for thawing, and then you keep immersed in a hot distilled water for another 20 minutes for proper tumor kill. Then you do the same procedure, do a fixation, do a reduction, and do a Prolene mesh reconstruction for additional safety. Again, when there is a short resection length, say for example 12-13 centimeter, we can actually avoid an osteotomy, which is known as pedicled cryotherapy. So what you do, rather than doing a wide excision, we just do a wide separation of the humerus, and then we close the wound temporarily, and the bone just juts out of the body as a pedicle. You do not take the osteotomy. Then you do a multi-layer protection, remove all the soft tissues and margins, and make multiple drill holes in a staggered fashion to reduce the chances of fracturing while freezing. Then you just, without taking the osteotomy, you turn it down and you dip it and immerse it in a liquid nitrogen for 20 minutes like this. Again, do a thawing at room temperature. Again, put it in a distilled water for another 20 minutes, and just do a simple reverse shoulder prosthesis within that bone. We always put a plate to protect the cryo, non-cryo junction from fracturing. And this is how an immediate postoperative X-ray would look. Postoperatively, the active shoulder movement is started after 6 weeks. Till then, pendulous exercises are allowed. You come to results. You take out the surgical data. Our average resection length was 14.6 centimeters. 8 to 23 was the range. We did 8 ECRT, 3 extracorporeal cryotherapy, and 7 pedicle cryotherapy. We used plates for fixation or augmentation in 16 patients, and only implants or with interlocking bolts were used in 2. Our average surgical time was 4.15 hours, and time pertaining to tumor sterilization was 1.5 hours. We have mean follow-up of 47 months. Oncologically, we have 1 local recurrence and 5 systemic metastasis, meaning by 5.5% local recurrence rate, 73% disease-free survival rate, and 78% of overall survival rate. We primarily looked at the functional outcome. We have looked at 3 parameters: musculoskeletal tumor society scores, U-class shoulder scores, and constant Morley scores. We had 91% osteotomy union at an average of 6 months time to union, and we got 90% abduction in every patient with an average time to 90-degree abduction to 7.5 months. We could get an average abduction of 122 degrees Celsius and average forward elevation of 124 degrees in our series. Our functional scores, MSTS functional scores was 88.3%, and average U-class shoulder rating scale was 80%, which quantifies this to be a good functional outcome. Our constant Morley score was 77.5%, ranging from 55 to 87%. And average ISOL's graft incorporation score was 95%, ranging from 16 to 32. Let us see some cases. This is the first case. This is a standard chondrosarcoma intraosseous of proximal humerus. Do a standard ECRT reverse glenoid composite. It was a short resection. We just put in an uncemented device. As you can see, at 9 months, it has beautifully healed. At 7 years, there is no resorption. In fact, the bone has consolidated. You see its function, and you will see how beautiful the function is. This patient has got near normal range of movement. Second case, a young boy, osteosarcoma, excellent response to chemotherapy, same extracorporeal radiation therapy, reverse glenoid composite fixation. As you can see, he can lift both the volumes of Campbell in one hand. So that is the strength that he has regained. Third case, a long segment involvement in Ewing sarcoma. This patient had almost entire humerus involved, ending just above the olecranon fossa. This patient would have otherwise underwent a total humerus replacement, but with this procedure, we could give her an excellent functional outcome with preservation of elbow joint. You can see the entire humerus has been put back, and 5 years this patient is enjoying an excellent function. Fourth case, again this girl, Ewing sarcoma, excellent response to chemotherapy, underwent an extracorporeal cryotherapy. This was the immediate postoperative X-ray. At 6 months, as you can see, at 4.5 years, this patient is having a good range of movement and no resorption of the cryotherapy bone. Fifth case, again, this is a patient who underwent a pedicled cryotherapy. As you can see, this patient has an excellent abduction and an excellent forward elevation. We had our share of complications. We had 1 dislocation, which was the first case that we did, and we had 1 insertion fracture. We had also 1 local recurrence, which had to be excised and then radiated, and then patient was controlled. This led to 2 revision surgery for mechanical complications, which is only 11%. If you look at this case, this was the first case that we did. The patient healed beautifully. I did something funny in the gym. It dislocated 10 months. When we opened for reducing the dislocation, we realized that there was a beautiful anchorage of the soft tissue around that radiated bone, and there was nice bleeding from the bone, substantiating that this is a viable graft. If you look at this case, this boy had an insertion fracture at the time of implantation. It was a very nicely fit prosthesis. We thought it is going to unite. Unfortunately, it went into non-union. By the time, unfortunately, that boy had already developed metastasis, so we just cemented the stem back into the remnant of the humerus. Till he survived, he enjoyed excellent functional outcome. Coming to the discussion, the first 2 questions: does this type of reconstruction work, and what is the complication rate? Well, it's not a new concept. As you know, the first data on reverse tolerated tumors was published in 1998. So it's more than almost a 3-decade-old concept. If you look at multiple papers, people have tried all sort of things. They have tried allografts, they have tried nothing. If you can see this image, they have tried nothing. They have just put in a long stem on that. People have tried megaprosthesis or just a cement around the open part of the prosthesis. If you look at the functional outcome and mechanical failure of these patients, if you can see all these papers, the mechanical complication rate was average 37%, which was only 11% in our series. If you can look at this dislocation, average 36% are in 5 patients, loosening 70%, none in our patient, non-union 9% as compared to 66%, no glenoid notching and no resorption graft as compared to others. So overall reoperation rate in our series was only 10% as compared to 41% in the previous published series. This was our first case which got dislocated. When we opened this, we realized that it was a surgical error. We had put this glenoid socket, the glenoid socket upside down, and that is, if that was properly put in, this complication could have been avoided. And here, if we had put in an additional plate, this complication could have been avoided. So these were our first 2 cases. After that, we have done another 19 cases, and none of the other 19 cases have had any mechanical complications. What is the functional outcome? If you look at the other series, the average abduction, forward elevation, MSTS scores and constant Morley scores are far superior in our series as compared to the previously published series. 122 degrees as compared to 116, 124 as compared to 100 degrees. MSTS scores 88% as compared to 75, and CM scores 75.5, 77% as compared to 65%. Whether is it more economical or not, and what are the other advantages? As you can see here, there are many advantages. There is excellent bony union rates, there is no resorption, the soft tissue heals back to the recycled bone, and that gives you a lot of leeway or options at the time of revision surgery, because these are all young patients, they are going to require revision surgery in future. If you compare these 2 patients, this is a constrained design, this is an unconstrained design, so of course the outcome, the range is far superior as compared to other techniques. More importantly, we have a lot of off-the-shelf available implants. At least 8 companies have registered in India and counting. It is available off the shelf and is uncomparably more cost effective as compared to those. As compared to 6.5 to 7 lakh rupees for implant, this is only 180,000 rupees for evaluates plus LCP plus tumor sterilization. If you had to point out some limitations, you can say the procedure time is more, because we spent 2.5 hours just for tumor sterilization and reconstruction. Because radiation facility is not available at our clinic, we could save actually 45 minutes of transit time if it was done in a place where the radiation was available. But we didn't have any infection in our series, so you can say it was not really significant. And the other limitation would be to short follow-up. It is around 4 years follow-up, and more than 3 years, less than 3 years follow-up in 4 out of 18 patients. To conclude, it's an oncologically safe, more biological, more functional technique with minimal complication. It is readily available and more cost effective. If I can get a minute before I go away, it would be unfair if I don't thank those people who have helped me achieve this. Incredible people who know their job, my team, my amazing teachers and mentors who have been supporting me all this life, and most importantly, my family, my parents, my sister, my daughters, and my wife. I always feel there is no better teacher than life. We should try. Whether to fail or succeed, it will be an experience. So I can say thank you very much. I am blessed with everything I need. I am working hard towards everything I want. And most importantly, I appreciate and thank God for what I have. Thank you.
Thank you so much, Mandip. As we all know, Young Surgeons Forum Award is a very prestigious and esteemed award of Gujarat Orthopaedic Association. And I'll just share a snippet, because when Mandip actually sent me the presentation, I actually, when Vijay Bhai was also telling or describing him as a young and handsome surgeon, I actually had to ask for his Aadhaar card, because he has been in the practice for so long, I thought he would fall in the veterans category. But all the same, Mandip, you have been always not just a pioneer, but also an innovator. And you have not been just thinking out of the box, you have been thinking as if there is no box. So many, many thanks for your presentation. And may I now request the President GOA, Dr. Vijay Sata, to felicitate Mandip on this occasion. And may we have a big round of applause. Mandip, by the way, hearing that this was your possibly the second one, I'm going to possibly suggest like Lata Mangeshkar.
Well, let's move forward to one person who doesn't fit into that category as such. But as Ketan has already said, we had asked for the Aadhaar card and actually falls into the veteran surgeon forum. So let's call another young dynamic person, Dr. Vikas Jain, to be on the dais, who doesn't look like being a veteran, but his Aadhaar card says so. Welcome. And he's going to talk about something very new, innovative, that is 3D printed bone for very complex situations in orthopedic scenario. And we all know him as a techno-savvy person and always smiling and always a friendly fellow. Dr. Vikas Jain for
Good
Veteran Surgeon
afternoon
Forum.
all. Thank you Gujarat Orthopaedic Association and the Baroda Orthopaedic Association for having invited me here to present something which is very unique, something which is very different, and something that's going to perplex you. So the topic itself is a little perplexing. It says patient-specific, customized, 3D printed prosthetic titanium trabecular implants in case of complex bony defects. So there are so many aspects that we would like to explain in this before you actually understand what it meant. Before I start, Om Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Param Brahma, Tasmai Guruve Namah. With deepest reverence, I bow down to the Supreme Consciousness, the eternal source of wisdom, light and truth that pervades beyond all existence. Brahma is absolute and it's the reality. In its boundless presence, all illusions dissolve and the self merges with the infinite. Equally, I offer my heartfelt gratitude and respect to my teachers, the guiding force in my journey of transformation, knowledge and realization. Through their wisdom, patience and unwavering guidance, I have come to perceive the deeper truths beyond orthopedics. May I always remain a humble seeker, surrendering my ego to the feet of the truth, ever learning, ever evolving, and ever devoted to the path illuminated by the Supreme Brahma and my gurus, Dr. Vaishnavi, Dr. Panchal, Dr. Naveen, who are sitting right in front of me. With deep gratitude, I extend my heartfelt appreciation to the visionary surgeons, because without them, it would not have been possible to create this small study. Dr. Tanna, Dr. Maini, Dr. Mukherjee, Dr. Abhishek Kini, and Dr. Kumar Shantanu Anand, who believed in the transformative potential of 3D printed implants and technology. Their courage to embrace innovation, precision in execution, and unwavering commitment to patient care have paved way for a new era in orthopedic surgery. Equally, my sincere thanks to the patients who place their trust in this technology and in the skilled hands of these surgeons. Together, the surgeons and the patients have forged a path where technology meets humanity, precision meets compassion, and innovation meets hope. I also extend gratitude to the jury of this paper who saw merit in it and made it possible for me to present it here today. Thank you so much. Special gratitude to Dr. Naveen for enabling this technology concept to a research paper. Sitting right in front of me, thank you Naveen bhai. This journey of redefining possibilities continues, fueled by trust, dedication, and the shared vision of better surgical and patient outcomes. Bite to bone, the digital technology in orthopedics. Friends, when we talk in terms of bite, we are talking in terms of something which is digital. And there are so many things that are happening on the technology front in orthopedics that we should know. I'll funnel it down, but let me have a broad idea about what is happening as far as technology is concerned in orthopedics. So 3D printing and patient-specific implant is one small subset. All of you know about robotic-assisted surgeries. Augmented reality and virtual reality we have started to use in the orthopedics in day-to-day practice. Artificial intelligence and machine learning we already started to use. Wearable technology, we have started to use HoloLenses for arthroplasty. We are already doing a lot of cases with that. Telemedicine and remote monitoring is common, you know about it. 3D imaging and advanced visualization is very much possible now with newer technologies, smart implants, navigational systems, big data and predictive analytics are going to be future. We'll be seeing a lot of things now coming up on basis of machine learning and AI that will be using data analytics for a big data. And wait for this future, bioprinting and tissue engineering. It's going to change the complete face of orthopedics. So as Dr. Samir was saying, you know, we need to unlearn and relearn. And that is very important, and that's the core of this conference. But as Socrates has said, that I am the wisest man alive, for I know one thing, that I know nothing. In fact, it's very difficult that there are so many truths we hardly know. It's just the collective experiences that we share here. So to start with 3D printing, friends, the information that we get in 3D is not only for diagnosis, but it can be used to make products, instruments, implants, and bring the disease out of the body, understand the complexities of defects, deformities, and plan the best patient outcomes. I was talking to a few of them. I told them that we still are in the practice of using CT scan and MRI for diagnostic purposes. Now you can use that information, you can take it to the 3D printer, you can actually print the bone, the disease, and you can have it in your hand within 1 hour. When you see it in real time, you can explain it to the patient, and you can as well as practice and understand your surgery on that. So that is the power of 3D printing and 3D technology. Preoperative planning is very important. We'll talk about it. We all need to understand the importance of preoperative planning, and this technology has enabled us to do a lot of preoperative planning. Trauma, complex trauma, you know that if we don't fix it well, and if there are series of complications, we end up into defects or deformities, and then you need to correct it. You can use this technology. We'll say few cases. Tumors, as Mandip told, once you have a tumor, you're definitely going to have a defect. You need to have jigs, which will enable you the dissection with margins, and then you also need an implant. Arthroplasty is very important. Now is the era of revision arthroplasty. We have to understand that aseptic loosening is causing a lot of problem. You are going to have cases with a lot of bone loss, and those bone losses in revision arthroplasty is going to create havoc. That's where we have to use this technology in order to get back the anatomical construct. So plasty has a big indication there. While pediatric and adult, in cases of deformity, yes, we know that the deformity is in all 3 axes, and hence you have to have a 3-dimensional workout on a software to understand and correct the deformity in X, Y, and Z axis. So what was the purpose? The purpose was, is it possible for us to innovate and design, as well as develop and manufacture patient-specific 3D printed trabecular titanium prosthetic implants in cases of very specific musculoskeletal challenges, wherein is it possible to have a prosthetic implant that is going to osteointegrate, as well as is it possible to have an implant that will enable us metal on cartilage bearing. Now these are 2 things which is the base of this study, the core of this study. So it's an innovative preliminary short-term retrospective study which gives an insight into customized solutions of trabecular titanium implants, which are designed meticulously by experts, orthopedic surgeons, and its behavior into human skeleton, osteointegration and range of motion by metal on cartilage bearing, improving the patient's life and the patient outcomes. Not only that, it reduces the surgical time, it reduces the surgical stress, and it also reduces the blood loss. So we were focused on 2 challenges, friends. Still we know that osteointegration is a very big challenge, but now no more. We all are facing a lot of challenges in our day-to-day life in orthopedic surgeries because we are not very sure that the prosthetic implant that we are going to put is going to biologically integrate with the bone or not. But with this technology, we are so sure that the implant will definitely integrate, and we'll see how. Can we use this technology to overcome this challenge of aseptic loosening of implants, and can we recreate the anatomy, integrate it well, and how well is it going to function physiologically? Well, another surprising part is metal on cartilage bearing, and this is what we would be seeing in few of the cases, and then you will get to actually understand how does this technology enable a metal on cartilage bearing. The objectives were in two aspects. One was the pre-operative aspect, which was involving the designing, and the other one was the intraoperative and the post-operative aspect. Well, there are 5 cases. We'll go fast in showing each and every cases. The materials and methods were like, all of you need to send me a CT scan, or you can send a CT scan which has a definitive 0.6 mm slicing. We need to do a segmentation. We need to create an STL. We need to create a bone model. We need to plan an implant. We create a prototype. We take a consent of the patient. We create jigs and guides for you to do intraoperatively. Then we metal print an implant. Then there is packaging, sterilization. There is a surgical plan that is given to the patient intraoperatively. He exactly uses it that way, and he's able to perform that surgery. What is 3D printing? So we, as an orthopedic surgeon, have not yet understood that how the implants are made. So we know about how implants were made previously. That was forging. You would molten the implant and then would put it in a mold. Then came the era of CNC. That was a subtractive, where you would have a pipe or you would have a plate, and then it would cut it into the shape. Now it's additive layering. So additive layering is nothing but it's a powder of a metal which is then sintered at a very high temperature, and it will give any shape that is required. And that is how this technology has enabled us to create a very anatomical implant. Osseointegration principle is most important, where by using this technology, what we do is we create trabeculae. Now, trabeculae is very important. What it does is it mimics the trabeculae of the bone. And when this trabeculae mimics the trabeculae of the bone, it is bioactive, predominantly titanium, and it integrates by means of osteoinduction, osteoconduction, and proliferation of the cells inside the interconnective channels of the implant, and it lays down the extracellular matrix. What is important is for us to understand 2 things. One is Young's modulus of elasticity and the Poisson's ratio. This is not what is much understood by the orthopedic surgeons. However, when you innovate and when you design an implant, and when you are looking at something where you want to osteointegrate, you need to understand these 2 principles, where you need to create an implant which has got an Young's modulus of elasticity which is near to that of a bone, and you need to create a Poisson's ratio which is also almost near to that of a bone. Now that is possible by engineering. Metal on cartilage, 2 principles. You need to create an absolute congruency over the cartilage, create a coefficient of friction which is less than 0.002. So under loading in a lower limb with full range of movement, there has to be a surface loading and not a point loading. Under such circumstances, even if it is a metal on cartilage, it will not damage the cartilage. Complex bony defects, there are many, and there are many possibilities of treating them by autografts, allografts, Elizaro, masculine techniques, 3D printed implants, and bioengineered scaffolds. Sometimes we have to do an amputation in case of a salvage, but in case of necessity, but salvage is the most important, and this technology has enabled salvage. So let's see the first case fast. This was a case of a young patient, and it was a trauma, open trauma, and over the period of 2 years, this went on to get infected. By the time it landed up to the secondary surgeon, that was Dr. Tanna, there was a lot of infection with a gap. This gap that is seen around 14 centimeters is a gap non-union with the articular cartilage of tibia also damaged. And the sir wanted to do an arthrodesis, wanted to use an allograft, when he asked me that, can you do something in 3D printing? And that is when we gave him a specific idea about how we can make a spacer. And this is a spacer with a plate inbuilt, And there is an arthrodesis nail which was customized, which was made, and the patient was operated with this spacer implant. You can see that these were the jigs which were given intraoperatively for the cutting of the tibia for the proper placement of the implant. These were few intraoperative pictures, and this is what you can see. The patient who wanted to have an amputation, since 2 years we did not have a defect, which had a defect, and we could create a spacer implant, which was titanium implant, which also had a plate and an interlocking nail, which was customized. And what you see is immediate post-op after 1 month, and this is the last. What you see in the comparison of X-rays, you can see within 3 months, there was a bone that is seen within the implant. Another case of a pelvic trauma, again a trauma, over a period of 2 years, fixed with an infection. The secondary surgeon resolved an infection, removed all the implants, and it landed up into a situation where there was hardly any acetabular cavity. So the the surgeon wanted me to design an acetabular cup. What you can see on a CT is almost a pelvic discontinuity, hardly any acetabular cavity, no posterior or superior wall. So we did a planning. We were able to give a cup based on the native parameters. This was an acetabular cup which we were able to put. We gave a planning sheet. For the first time, we were able to give a rimming jig, which is very important because we need to have a proper center, inclination, and version when you are putting a tripod cup. These were the intraoperative pictures where he had used this. This is what you can see on an IRTV, and this is what you see now. The patient is able to walk with a shortening which was there initially. Now, patient is able to walk on that particular thing. We don't have a last X-ray, but this video shows about the patient. The third case of a recurrent GCT in a lower end of tibia. The surgeon wanted to preserve the joint, wanted a mobilization into the ankle joint, and wanted to design a 3D printed ankle plafond. We went on to design that. To go a little fast, they used the jigs. They removed the tumor part. They put on this implant. The FEA was done, and this is what you see. And the last you can see is, this is 2-year follow-up, and this patient with an ankle plafond, the way she walks. Another case of an AVN in the lateral condyle of femur in a young patient on the posterior 1/2, and she had an FFD, painful, she could not walk. They were contemplating an arthrodesis. While we decided to create a 3D printed implant, we have 1.5 years of a follow-up. This was an implant which was a trabecular implant, intra-articular implant. You can see how the intra-articular implant is behaving after having implanted. While immediate post-op, and now what you can see is a patient after 12 months. She's able to climb up and she's able to climb down. Here the design was predominantly focused on to save the lateral collateral ligament as well as the anteacrotial ligament, as well as to create a metal on cartilage bearing and osteointegration by creating trabeculae. Last case where we had a patient who had a zone 4 lesion in talus. Now this required an osteochondral plug. A detailed study was done and a trabecular plug, again based on osteointegration and metal on cartilage, was designed. You could see that there were jigs intraoperative that were made. These jigs were used by the surgeons. Medial malleolar osteotomy was done. The plug was put in the definitive direction as planned, and the patient is doing well. So what you see here is an immediate post-operative X-ray and the 6-month follow-up X-ray. What you can see is a congruency. We don't have a follow-up video of this patient, but I'm told that the patient is walking well. A new concept that we're coming up is for AVN, where we would work on using both the principles of osteointegration and metal on cartilage to create a focal resurfacing implant. Hence, 3D technology enabled a precise study of complex defects, enabled preoperative planning of the solutions in all cases. The software enabled the design and jigs that precisely fit, reduced the surgical time, and all surgeons were stress-free intraoperatively. Post-operative outcomes were excellent. Surgeons and patients were satisfied. Osteointegration required 12 weeks to show radiological signs. All cases exhibited pain-free range of movement. Gait was painless 8 to 12 weeks later. Osteointegration and metal of cartilage bearing is possible with technology. Innovation with design concept is must. Hence, it is compulsory for orthopedic surgeon to participate in planning of a customized implant. Knowledge of basic material science, biocompatibility, engineering add to complete the understanding of implant innovation. FEAF offering implant, computer simulations are important too. Artificial intelligence and machine learning. So hence, friends, to conclude, optimize orthopedics and optimize mankind. 3D technology is the best way to understand complex defects and deformity. However, the software can be used to understand complex trauma and arthroplasty too. Pre-operative planning using software should become a norm. Those who fail to plan, plan to fail. Most of the cases we see in the future are the first surgery that is important. Aim to do the best first surgery. Complications otherwise will start to roll. Adopt technology if it shortens surgical time, reduces blood loss, and gives optimal results, and reduces your surgical stress. Do not compromise by using off-the-shelf implants if you have a choice of customized implants, but first biological option and then an implant option. It is not possible to design, innovate a customized implant without information, knowledge, and skill of an orthopedic surgeon. Use of jigs and guides for deformity, PSI defects, and implant osteointegration and metal of cartilage is a reality now. These are few global data of lot of many implants. Thank you so much. We are waiting for my book along with Dr. Lalit Maini. There are limits to this technology. Give me just 2 minutes. 1 minute. Understanding the limit of technology and its use is important as there are economical, ethical, and natural limits of technology. AI disruption is an example. Any technology that is justifying its use for optimal patient outcome, cost-benefit ratio should be well understood by orthopedic surgeon. Just because technology exists, should we use it unnecessarily? There is a fine line of delineation between human touch and mechanization in orthopedics. Technological advancement in orthopedics open new horizons, but they also raise pertinent questions about the limits of human intervention. Reflection help orthopedic surgeons to balance optimism with innovation, with caution over reliance on technology, Thank you so much for patient hearing. Thank you so much.
Thank you so much, Vikas. When Waljibhai Shakespeare talked that what's there in a name, he possibly had not dealt with Vikas, because Vikas is somebody who has been evolving and revolving into fresher and newer pastures, and we have seen the results that he can create with his baby of 3D printing. So many, many thanks, Vikas, and keep evolving and keep revolving. Thank you so much, and may I request the President GOA, Dr. Vijay Sata, to join me in felicitating Vikas. Thank you everyone for the strict time making.
And before we go, I want to say sincere sorry to the papers that could not be accepted for this innovative session in the young and veteran surgeon. They were excellent, absolutely excellent, and this time absolutely great competition was there amongst the submissions. And we are sorry that by the rule we can have only one in each category. Those were excellent, and I wish that in future they will be having over here only. Thank you very much.